I was reading a story yesterday, a headline about, somebody talking about a correlation that just didn't make any sense. And so I think it's hard for us, certainly as physicians with the scientific training that we've had, to even recognize that somebody would make that jump and then to be kind and empathetic and really share in a way that doesn't make someone feel bad, that they don't understand something that they should, or be condescending about it. That's always like the hardest thing for me. And so I often try to think about, maybe how would I describe this to my niece and nephew who are young, they're in elementary school.
Welcome to How I Doctor, where we're bringing joy back to medicine. Today, I'm joined by Dr. Shoshana Ungerleider, a practicing internal medicine physician at Crossover Health, host and producer of the TED Health podcast, and founder of the nonprofit Endwell, which focuses on transforming the end-of-life experience through film, media, and conversation. Shoshana has executive produced award-nominated Netflix documentaries that I love that use storytelling to reshape clinician mindsets and the culture around dying with dignity. I'm so excited to talk to Shoshana today because of her mastery of science and healthcare communication. In a time when misinformation threatens public trust in clinicians, and clinicians are navigating burnout and bias and rapid technology and workload change, her work, I think, shows us how physicians can use media and narrative not just to catch up with the change, but to lead it. Dr. Shoshana Ungerleider, welcome to How I Doctor. Thank you for being here.
Oh, Graham, thank you so much for having me. That was such a kind introduction. I'm honored to get to talk with you today.
Fully deserved. Shoshana, maybe we'll just start talking about your communication. There is so much misinformation and then less misinformation, but just hype out there. How are you deciding what is worth digging in deeper and deciding, this is worth me learning more about?
This is something I think about constantly because I think the line between education and hype can seem razor thin. And I couldn't agree more that the rampant misinformation out there is really threatening the health of society. I think my approach is probably pretty methodical. I try to start with the science. Sometimes I don't get to have a say always, especially with TED, on exactly what we're covering in terms of a topic. But I'm asking the question, is there peer-reviewed research? Are the studies well-designed? Are the researchers credible, right? And then I ask the harder question, what does this mean for people right now? Take, psychedelics, as you mentioned, there's genuinely exciting research happening around psilocybin in the context of major depression, existential distress in a palliative care setting for dying patients. But I'm really careful to emphasize that we're talking about controlled therapeutic settings with trained professionals in a clinical environment, not recreational use, right? I always try to include the limitations, the unknowns, the what we don't know yet parts. I think the public really is smart enough to handle nuance, but I think we need to come at this with honesty about uncertainty. And, I try to focus on stories that help people understand their bodies better and have better conversations with their doctors rather than promising some kind of miracle outcome. And I think the test I try to use is, would I want my own family members to hear this information? And if the answer is yes, right, and it's backed by solid science, then it's probably worth sharing.
I loved the way you said the public can handle nuance, but I think it's so critical that we mention it, that we communicate that. I think the easier answer, obviously, always in medicine is definitely do this, definitely don't do that, always this, never that. But we know as doctors, there's almost nothing in medicine that is that obvious and straightforward. So I think that's such a critical point that we have to mention it and make it clear that, hey, this is promising, but the idea that something works in a clinical trial is often so different than how it works, unfortunately, in the real world with way more complex elements.
I think what I have learned over these years of doing more public-facing science communication is that people are really hungry for health information, but they're also overwhelmed by maybe conflicting messages, especially in this moment in time, right? my philosophy is to kind of lean into the uncertainty rather than shy away from it. And I even in the early days of the pandemic found myself saying, because it was absolutely the truth, here's what we know, here's what we don't know, here's what the research suggests that might be true. And I think people really appreciate that honesty. I think it's actually necessary. And we need to be training clinicians in how to communicate uncertainty because it's not something that we're typically as comfortable with. And then, further, I try to give people their own tools, I think, to become better consumers of health information. So not just passive recipients. Again, like the pandemic taught us that scientific literacy isn't a luxury, it's a necessity, right? Yeah. For making good decisions about our health and our families and our communities. And so I always try to connect the science to the human experience. I think data without context is just noise for the general public. And I think when you can help someone understand how a clinical trial might affect their conversation with their doctor, or how maybe a new treatment might impact their family's decisions about vaccines, I think that's when science becomes really meaningful for people.
Yeah, the thing that feels frustrating to me as a doctor trying to combat misinformation and provide good information online for other people is that I think we are appropriately held to a higher standard. We have medical training, so the expectation is that a physician is going to give a more nuanced, maybe slightly less excited version of communication, but people who have no medical training and who may have a financial incentive, and often do have a financial incentive to sell their new probiotic or their new magnesium supplement or something like that. There's no expectation that someone else isn't lying to you online, but people would be very upset and think that there are, major ethical violations if a doctor were to do that. And so I think that's the other thing that's really challenging today is doctors are held to a different standard.
I couldn't agree more. And so much of what I end up doing on TED Health with my own family members in my day-to-day conversations with an Uber driver is trying to debunk the myths that are out there. And so it's with so much content, information available to people all hours of the day and night in every possible way coming at all of us. What do we do about that? It is so tricky. I certainly don't have an answer, but I think the more that we as physicians, as scientists can be talking about that, can be encouraging people to learn how to evaluate information for themselves, certainly teaching that to young kids in school, right? I mean, that starts way, way upstream and probably need to be doing a much better job of the scientific kind of literacy piece for young people. But it's so hard.
Yeah, even just basic correlation versus causation is such a critical thing that for human beings to understand and comprehend and to have that ability to have that. I think of that as one of the fundamental things that I always go to when I read a study or read a headline. It's like, oh, well, okay, is it possible that this is just a correlation? And I don't think many or probably most people think in that particular way.
No, it's huge. I was reading a story yesterday, a headline about, somebody talking about a correlation that just didn't make any sense. And so I think it's hard for us, certainly as physicians with the scientific training that we've had, to even recognize that somebody would make that jump and then to be kind and empathetic and really share in a way that doesn't make someone feel bad, that they don't understand something that they should, or be condescending about it. That's always like the hardest thing for me. And so I often try to think about, well, like maybe how would I describe this to my niece and nephew who are young, they're in elementary school, in a way such that they could really understand. I'd be curious to hear how you when you see patients, how you address that with folks.
So I liked your concept of imagining it's your niece or your nephew. I was going to say my mom, but
yeah. And my mom for sure.
Sorry, mom, that I get really frustrated when you ask me tech questions. So maybe that's not the best example. I think I always try to remind myself, like, get curious, not furious, and like, it's interesting that you think that. I would never have thought that in a million years. Tell me more. Like, let's see the question behind the question is what I try to do. I'm sure I'm not always perfectly successful.
Yeah, curious, not furious. I love that. Can I use that?
It's all yours. Hey doctors, AI isn't coming, it's already here. Whether it's scribes, risk prediction, or chatbots, AI is reshaping medicine right now. And that's exactly why I created the AI Secrets for Clinicians webinar. Along with my friend and Valdar Health founder, Dr. Sarah Gebauer, we compiled a practical guide featuring a roundup of the best tools, prompting tips, and educational resources for all clinicians to get started with AI. This is the starting point. You need to learn how to use AI safely, ask the right questions, and take the lead on incorporating this new technology into your practice. Visit offcall.com/AI guide. That's offcall.com/AIGUIDE to get started. Thanks. Moving from kind of news segments and podcasts and film, how have your strategies shifted when you're trying to tell a message or a story through different mediums, whether it's the podcast or it's some of your documentaries, which are outstanding. I mean, truly incredible the way they were able to like communicate what I feel on the physician side for, a patient who is maybe nearing the end of their life. Like, how do you decide what strategies to employ in various mediums?
I don't know that I always have been as proactive and well thought out as maybe, I got into a lot of this media work really by accident. So I can certainly speak to the particular questions, but I just want to put it out there that I thought I was going to be a full-time clinician, a hospitalist, doing mostly taking care of folks in the hospital. And then really these opportunities came to me in really unexpected ways, I guess I would say. And
where did they come from, Shoshana? Maybe tell us that story.
Early on in my training, I got really interested in how we care for folks facing serious illness and the end of life. And I was really lucky to have wonderful mentors in palliative medicine where I trained. And while I knew I didn't want to be a palliative care physician, I knew that I wanted to shift first how medical education is taught, or at least think through, how can we make sure that all trainees get, a core competence in communication skills and palliative medicine fundamentals. Started thinking more broadly about, what would it take to shift the cultural conversation, since so much of the reticence to engage with end of life comes from kind of the societal taboos, and there's so many reasons for that. And then certainly the perverse incentives in medicine that encourage us to always do more to patients as opposed to stopping and asking, what does this human being in front of me most value with the time they have left, and how can I best treat them in a way that matches what they hope to have in terms of living their life. So I started thinking, and talking to folks doing this work. And it just so happened that a colleague of mine, Jessica Zitter, who's an ICU doc and palliative medicine physician in Oakland, California, was filming a documentary in her ICU, Extremis, and got involved with that project really by accident, over coffee. Jessica and I were talking about the project, and she sort of said, "Oh, I know you're interested in kind of the broader conversation in society about end of life, and I've always felt like the ICU is the place where so many of these conversations are so concentrated and emotions are so heightened and the medicine is so complex that wouldn't it be wonderful if people could see what takes place in an ICU, not only from, the patient and family perspective, but also the conversations that clinicians are having about care for seriously ill people. And so got involved with that one. And then we were super lucky in that Netflix decided to start buying short documentaries that year. And then it was premiered at Tribeca, and then I was like, whoa, there's something here. I have no background in film, like zero. I like romantic comedies. Okay. Like documentaries is not something that I was ever on my radar. And then it was nominated for an Academy Award, which showed me that, wow, there is an appetite for this kind of content out there, and shining light in some of these hidden, darker places, especially as it relates to end of life, is such a wonderful way for educating the public so that they can understand what goes on in hospitals and hopefully be able to make better decisions for themselves and the people they love when it matters. So to get back to your original question, I think the other work that I've gotten into with podcasting and television, each medium, I think, requires a very different approach. News segments, right, are about clarity, being concise, and urgency. You literally have 2 minutes to make one clear point that's going to stick with viewers. There's not much room for nuance. So you have to be very disciplined about what you're trying to accomplish. I think usually it's about getting people to think about one specific thing and why it matters to them. I think with podcasts, as you know, depending on the length, you have more luxury of complexity, and you can tell a longer story. And I think that's where, I've really tried to dig into more of the systemic issues in medicine. And then film is different altogether. I think film can, in a beautiful way, bypass the kind of intellectual defenses that people have about difficult topics. And so I think that emotional connection is what creates, well, hopefully, lasting change in how people think about some of these issues. The key thing I've learned is that you can't just take the same message and put it into different formats. I think you have to think about what each medium does best and then craft, an approach accordingly.
It really reminds me that like everything that we are trying to do is around impact. And I think the physician version of that is like outcome. Just doing this podcast and learning about marketing and doing things for off-call. Like I've been really impressed at how much broader the world is outside of medicine. I mean, I think as a physician, I think, I have a weird kind of, it's kind of like a know-it-all, like, oh, I've got all this. And then you step outside of it, whether it's a podcast or a documentary or anything else, and you realize, oh my gosh, there's so much else out there that can help me make an impact or help me take better care of my patients or have better outcomes as well that isn't in the house of medicine specifically.
Absolutely. Yes. I think there is a whole massive, somewhat scary world out there of things going on, and it's a lot to learn. I mean, I think early on when I was thinking about how do we change medical education and think differently about caring for people at end of life, I went to a bunch of conferences in the world of hospice and palliative medicine, and I met incredible people doing groundbreaking work, and they'd been doing it for decades, but we did a lot of preaching to the choir. I think that, academic publications are incredibly important. People doing, the research, it absolutely has to happen. I mean, that's the core. To me, it's about broadening our spheres of influence, trying to, especially as it relates to changing the conversation around end of life so that more people can get care that's aligned with their goals and their values, and educating the public about what palliative care is. For example, we must think much more broadly than beyond the walls of our hospital, our clinic, or beyond the readers of academic journals. I think, to me, it's really, really important to think about the bigger conversations that are happening out there. But it's certainly tricky because we tend to like to be head down, or we don't have time to not do that and stay in our lanes. And I have just not done that.
It reminds me of a couple studies that are related to end of life and palliative care that probably need to be repeated now. But I think one study looked at the outcomes of CPR on television. I think from like the shows ER in the 90s, and like 95% of people who get CPR survive. And then I think there was another study that looked at what does it mean if someone's on a ventilator? And a lot of people thought, you can still talk on a ventilator. You can still interact with your, family. You can, walk around, blah, blah, blah. And I think it is such an important point that people in healthcare, or especially people that work in a hospital, whether it's physicians or nurses or social workers, we have a very specific understanding of what it means to get CPR, or what full code means, or what being on a ventilator means, and then extract that out. And we have hundreds or thousands of opinions from the general public about what that means. The range of understanding is so critical that I often think that physicians are talking way over here about something, and then you've got like what the patient actually is receiving or understands is way over here. It's an entirely different understanding. They're literally not even saying the same words and having the same definitions.
Yes, couldn't agree with you more. And actually, Graham, Endwell, a couple of years ago, started looking at how do television portrayals of end of life, whether it be, CPR, ventilators, conversations about hospice and palliative care, influence viewers of TV shows. And so we did a study, a script analysis looking back 10 years. So not all the way back to the early days of ER, even though I love that show, in terms of how those topics were discussed. And then looking forward, how can we work with TV writers to make sure that they're, to encourage them, let's say, to be more accurate with their portrayals of things like CPR, of not just showing, acute violent death being the predominant thing on television, even though that's maybe what people want.
Dramatic and exciting. And
exactly. But and to show more balanced conversations for people on the medical shows, for example, like how The Pit has done such a beautiful job. We were lucky enough to get to help influence some of that work that they highlighted around in the ER, like the pause. So when somebody dies, they take a moment to recognize that life, or the more nuanced conversations about advanced directives, and that show just did such an incredible job of that. I don't know if you agree, but I think that so many people of varying ages throughout their lives are primed with information that they get from television, right? And so, how can we again encourage more accurate storylines so that people can really be armed with the right information at the right time when they need it to be able to make the best decisions for their loved ones and themselves.
Yeah, I think the power of media is it helps maybe people reframe or have a different understanding about a particular topic or idea. I'm sure both of us have had scenarios where we might not agree with a patient's decisions, whether it's about end of life or treatment or anything like that. And I sometimes you start to butt heads and you realize this doesn't seem to be going anywhere. This has stopped being a productive conversation. But I think media has a way of subtly getting in there, and maybe I'm not able to change my patient's opinion about a tetanus vaccine or something like that today, but you could imagine a podcast, a piece of art, an episode from The Pit, something could make them just kind of question things because their defenses are maybe down a little bit more at when they're being exposed to that.
Yeah, I think media is certainly one tool. Although now that I've been reading much more about misinformation, especially in this moment in time, and thinking about how do we educate folks and maybe change minds about things that are incredibly important for public health, I think certainly what they're seeing on TV, how we're communicating with patients, I think from the top down in terms of our political leaders and policy decisions are incredibly important. I know that you're somebody who has had politicians or conversations about what it looks like to have physicians in these positions. I also agree that's incredibly important. I think the pandemic really showed us how crucial it is to have physicians who can communicate effectively with the public. When you have political leaders who understand both the science and the human impact of policy decisions, we're seeing that play out in a big way. So I am concerned about what's going on in this country, but I'm hopeful that it will encourage more of our colleagues to get involved in the political arena if they can.
Yeah, I think we're seeing that. I think we're seeing people running for Congress. Dr. Tina Shaw is an intensivist in New Jersey. She's, I think, also just having more physicians speaking out. Traditionally, medicine is not a place where we publicly broadcast our opinions about things. And, we've had Dr. Elizabeth Potter, who spoke out about, how she was treated by United Healthcare. And so I think we're seeing more people just sharing what it's a prior auth. What does your doctor actually have to do to get Zofran approved for somebody with cancer? I mean, it's crazy. But I think that's such a positive way to look at things right now, is this is actually encouraging more of our colleagues to speak out about what it's like to practice medicine today.
Yeah. I mean, I think we actually have to, as much as I hate to say that.
Yeah, it's like a requirement now. Yeah.
Yeah. We cannot
take it for
be
granted.
Silent. Yeah. No, absolutely.
Shoshana, given your coverage of chronic pain bias on TED Health, what prompts or tips might you recommend for clinicians to check in during their clinical encounters?
The question of self-checking for bias is crucial. And I think the most important tool maybe is simply pausing and asking yourself, what assumptions am I making about this person right now? And it's wild to kind of sit with what comes up, for all of us. I try to use something like what I call the switch test, meaning if this exact same patient was a different gender or different race or age, would I be responding in the same way? Would I be as likely to believe their pain, maybe if that's coming up, or would I be as quick to offer certain treatments? So I think that that's a helpful tool. And then I also think noticing body language and tone. Are you maintaining good eye contact? Are you sitting down or standing up with this patient? Are you rushing, through this interaction? What's triggering you to do that? It's interesting. It's interesting to me. You might think this is crazy, but I earlier in the year did a death doula certification course. And it's not because I'm planning to practice necessarily as a death doula, who is a non-medical person for patients and families facing the end of life. I thought that doing a course would help me better understand the process and the work. But I was blown away by how much I got out of the coursework that was really focused on bias and recognizing where my triggers are in life. Because we all, even though
What? I don't have any triggers. I don't know what you're talking about.
Right? I know. Well, we don't. I mean, at least I didn't in medical school think about, how my own personal upbringing maybe, or my own personal journey affects the way that I care for patients and show up for people. I was recognizing that I was getting uncomfortable or feeling pain in my neck or a racing heart rate. And I was like, what is going on here? What is triggering me about this conversation? And it really got me to do some interesting inner work that I never in a million years thought I needed. Or I really, I assumed that I had that piece, sorted out, because of course I can stay objective. I've cared for people who are dying, hundreds, thousands of times, and it's not an issue for me. And it turns out like we all bring our own stuff to every encounter. And in thinking about how we can best show up for our patients and their families, I think that's actually a really important thing to be looking at.
One of the things that I think is really important is that physicians are able to let our patients know that we are human beings, and we bring our personality, we bring our perspectives and our flaws to the table when we are taking care of patients as well. I think one of the key points there is that these are skills that we have to hone and get better at, is looking at our bias, how to communicate with people with serious illness. Just like I would never just tell the med student, oh yeah, can you go drop a central line in room 7. That is it's a skill, just like any other procedure that we do. We have to learn and train and get better at these things. These things are not automatic, just like a central line is not automatic, intubation's automatic. All of these things are things that we can get better at, growth mindset we can improve upon over time and training and taking a course.
Again, I was super lucky. I know I mentioned this before, to have wonderful mentors in palliative care, in my ICU rotations, on the medicine, wards, and really got to see just how life-changing a skilled, thoughtful conversation with a family can be. But that is not something that I think even now is widely considered to be important and valued as part of medical education. And I think that really has to shift. I mean, it's been now about 8 years, but I know a JAMA survey looked at what practicing physicians reported in terms of their training in how to break bad news and how to talk about difficult subjects. And 70% of practicing physicians said they had had no training in it. And we do our patients and their families such a disservice by not having that skill set. Again, this is not just for primary docs or people in the ER on the front lines. This is for subspecialists too, because so much of our system is fragmented into these specialty places where it's going to be the job of the medical oncologist, say, or even the nephrologist to be bringing up palliative care potentially or talking about prognosis. And I think it's incredibly important that we not only value it as a healthcare system and reimburse adequately for it, but then also just as human beings see that communication is really just incredibly central to our work as healers and doing the best job we can for our patients.
And Shoshana, I would add that so much of medicine now is management of chronic disease. And so it's not curative anymore. And so we all have to be able to talk with patients and communicate, hey, you have this condition this is not something that I'm going to be able to cure. We're going to be managing it and trying to stabilize it and maybe suppress